Hello. It's been quite some time that the artificial intelligence has been a buzzword elsewhere we go. It's much popular to write poems, but you might have seen the meme that is populated in the Instagram or elsewhere in the social media that says, I don't need artificial intelligence to write poem, but to wash my dishes or to do my household chores. In this episode, we are going to look at artificial intelligence from a different perspective, from the perspective of the eye care. I met the LV Prasad Eye Institute in Hyderabad. In this episode, we are going to look at a program where researchers at the LV Prasad Eye Institute is using artificial intelligence and a mobile application to detect cornea-based diseases much early in the diagnosis stage. Hi, I'm Ananda Padmanabhan. You're watching the Ground Reports.
Amongst most diseases of the cornea, corneal infections are probably the most prevalent from the point of view of a sight-threatening disorder that affects the front of the eye. The reason why they are so prevalent is probably because of our agrarian economy. A number of patients who are in agriculture, they tend to get minor injuries while working on the farms, with leaves, with thorns, with dust sometimes. And if these are left untreated in the initial phase, they can lead to infection to the front part of the eye. And corneal infections almost always leave behind a corneal scar. Like this is like a white spot on the cornea. And these corneal scars, unfortunately, don't have any medical therapy at this point. They need a corneal transplantation for the patient to see better. If we are able to detect these infections early and to be able to prevent them from developing into much more severe infections, we would be able to prevent these patients from requiring a corneal transplant eventually. And that is the goal of being able to move the ability to diagnose these infections, not in the urban areas, but to move that ability to the rural areas and put the ability to diagnose infections in the hands not just of ophthalmologists, but also of community doctors, community health providers, community health workers who have faster, easier, and closer access to patients who develop these infections. Just from the presence of qualified eye health professionals in different parts of our geography, the majority of specialty eye doctors are present in cities. Some of them are present in large district headquarters as well, but there is hardly anyone that you will find in a village setting or somebody who originates from a village will have access to. A health professional on the ground who is not a qualified eye specialist has the ability to examine these eyes, and these are cadres of people who are already present in the rural areas. They can use a torchlight, they can use a mobile phone to take a photograph of the eyes, but then they're probably not able to proceed even beyond that. So if we enable them to make the right diagnosis using like an algorithm that can detect these infections from a simple photograph taken on a mobile phone, we believe that we will empower these people on the ground with the ability to diagnose these infections early.
Here we analyze the different diseases of the eye through imaging, and we grade them whether they are having diabetes, whether they are having age-related macular degeneration, or whether they are having glaucoma or any kind of eye disease. So we collaborate with other teams like other sites, and we also undergo many clinical trials imaging.
This is the anterior segment of eye. This is a fundus image. We grade the disease type of DR to identify the disease stage. The camera will be captured the eye through the people. So in that people, we capture these images like fundus. From the outer part of the eye, this is the slit lamp. This is the inner part of the eye. So this is the fundus image. In that, we degraded as this is the disc, this is the macula. In this any damage will happen, we will grade as the stage of the DR.
You scan the picture of the eye and mark different part where the contrast is present, and then name it or label it accordingly.
Yes.
We had a set of images of all the infections throughout the years that we have captured. So we started developing a machine learning model on the basis of these images. Not just infections, but there are other corneal conditions which can mimic infection, like an edema. It could be a scar. Scar is a state where infection is resolved. Edema is kind of swelling in the cornea. So we started by annotating all these features and helping the technicians to learn this, and then that is how a ML model is created using these images and the annotations that we have done.
So typically what in ideal conditions an ophthalmologist would do is to actually take a sample of this infection, send it to a lab, and then within 2 to 3 days get a result as to whether it is a bacterial infection or a fungal infection. So what our model is trained to do is to pick up just based on the photo of whether this particular infection is bacterial or fungal. So what it does is that it gives the doctor a head start of about 2 to 3 days to actually start the correct treatment.
So there is specificity of the photo taken. Does it have to be this good? Can I just shoot it with my mobile cam and just upload it?
So we do suggest that we have built a very small application known as the Grabby. So smartphone images are also good enough. So in order to optimize the way the image is taken, there is a small application along with a small addition that can be clipped onto a smartphone. So this ensures that the distance from the eye is adequate and correct, and also does some minor tweaks with the resolution as well as the flash, so that a good quality image can be taken to process. But the model is capable of processing images that are of lower resolution or may have been taken directly with a smartphone. So it comes with a layer of image quality detection. If it is not satisfactory enough, the model would return an input saying that a better quality image is required.
So the data that we use to train and build these machine learning models is coming in from our own institute, where we use EMR systems as a primary critical system to capture the patient records.
What is EMR system?
So it's called electronic medical records. So we created our own in-house EMR system called iSmart EMR, which has been perfected over 15 years of time with all specialties of subspecialties of the ophthalmology. Now that is our source of truth for all the data, all the patient's data, including the images. So for us to train the machine learning models, the data has to be in a specific format or at a specific quality level. So for us to get the data to that level, we need to do some kind of data operations, which includes cleaning and also translating and enhancing and enriching these data components for the model to understand. So this is called the data exploration activity, right? So before we start developing any model, we do this data exploration activity where there are multiple tasks involved to clean the data, to make that data ingestible to the ML models. Now this is a huge exercise where the data scientists will actually involve our clinical specialists to understand each of those data components and how do we translate those values. We have to mimic the thought process of the clinicians on arriving at an outcome. So we cannot actually directly create a model, AI model, that will give you a final outcome. So we need to train the model to think like the doctor or the ophthalmologist or optometrist, to take in this data and how do you process this data to arrive at the final outcome. So there are different steps. So it's like teaching a child, right? So our data scientists employ multiple techniques to actually teach the model on how to think about each stage, each process. After at a certain stage, few techniques will be employed to improve the accuracies or the outcomes of the model. Now this is done again with the help of our clinicians to understand why for a specific patient, why the model has given a specific output. So we always employ a technique called explainability. So when you talk about AI systems or ML systems, everybody thinks that it's a black box. Nobody knows what happens inside, but they get an outcome. But what we employ is a responsible AI methodology where every AI outcome is accompanied by explainability. When we give few inputs to the model, the inputs are taken and crunched by the model, and then the outcome is given. Now, along with the outcome, there will be a graphical representation on how the model has arrived at this outcome. What are the factors that are contributing positively? What are the factors that are contributing negatively? Those will be displayed so that the clinician will understand how the model has arrived at that particular outcome. So this is the explainability part that we are actually baking into all the AIML models that we are building.
Here I have a question, like for instance, suppose a model has arrived to a particular conclusion, but then the physician himself or themselves might see it as a wrong conclusion. And whom do we trust the most?
Right. So here our intention is not to replace our clinicians with the AI models. Our intention is to augment the clinician's decision with the AI models, augment and support so that the decision is made faster and quicker.
Does that mean the final say is of the clinician?
Yes, always the final say is with the clinician. Now all the models, as I was telling, we have explainability built into the models. At the same time, we have feedback built into the models. So this is where our clinician in the loop or human in the loop philosophy comes in. So every outcome of the model, outcome that the model generates, the clinician feedback is captured in terms of whether the clinician agrees with that model outcome or not. If the clinician doesn't agree with the model outcome, why the clinician doesn't agree? This is actually captured for every outcome, for every run of the AI model. And this feedback is actually used to refine the model's accuracy going forward.
I think the world of machine learning and AI is something that all of us have been exposed to. And if we pause for a moment and look at the AI and machine learning models that we're using, most of it has an economic twist to it. Either the provider or the user has an economic benefit in using these models. When it comes to healthcare, either large healthcare providers will use AI models to determine where to put their resources, or you will have policymakers use these models to determine how to shape future policy. It is very rare to have doctors and healthcare workers to be at the forefront of driving innovation in AI from the point of view of earlier diagnosis and better outcomes of treatment themselves, which is probably the reason why we have a gap between developing models and implementing them on the ground, something that's called implementation gap. Because doing this also costs resources financially, human resources, takes time, requires support as well. And I think AI models that are driven by medical professionals based on a felt need to be able to provide better diagnosis and treatment to patients will probably have the most impact on the ground because they know exactly where the gap is and they're trying to fill that gap.